So we're going to have the panel discussion now, and two additional panel members are going to join us, Joel and Steve. Please join. And I think what should come as no surprise to anyone was that Claudia has never believed in that 15-year quit. And so I-ELCAP has always screened longer than the 15 years quitting. And we're going to be delighted to share those results and hopefully assist in getting this change from the U.S. Preventive Services recommendation. So just to start this panel discussion off, I wanted to bring in our two new panelists. Steve, you have enormous experience with mobile vans, with your Department of Energy program for screening. Can you just tell us a little bit about all of that, what your experience has been, where this is going, et cetera?
So, by the way, this past July 25th was the 25th anniversary of Claudia and David's publication in Lancet, on the New York I-ELCAP. So, I do occupational medicine, City University of New York, and we read that a week later, and within a year started lung cancer screening for Department of Energy workers. These are nuclear weapons workers, people who built our nuclear bombs, exposed to radiation, occupational toxins, and of course, cigarette smoke. And then we started year 2000. There were no radiologists to do lung cancer screening, so we employed a mobile unit. And it's a big hassle. We gave it up after 10 years. It was a tremendous amount of work, and I just want to recognize Amy Markowitz in the back who did much of that work. But it was extremely difficult. We ran it between Oak Ridge, Tennessee, Paducah, Kentucky, that's Western Kentucky for those of you from New York, and Portsmouth, Ohio, which is Southern Ohio. And we did that for 10 years and did scanning and sent all the scans to one scanner, one radiologist in New Jersey. But then we moved because at that point, 2010, there were a lot of increasing numbers of radiologists who did this. Now 1,000, I think, centers of excellence around the country. So we no longer use mobile scanning, although we do have a scanner, our own scanner at the Labor Union Hall in Oak Ridge, because we do that because we scan a lot of people in Oak Ridge, but we also do that because people are greatly attached to our program, and we have excellent adherence, excellent enrollment because they feel it's their program, because it's brought to them in association with their labor union, or could be a community group. But that success is outside the healthcare system because of their attachment to the program.
Just to bring Joel into the conversation. Joel, I know we've talked about physician burnout with all of these results. Can you tell us a little bit also about maybe patient burnout with getting all of these findings?
Well, there's a lot. Sure. Hi there. Good afternoon. My name is Joelle, and I've been a nurse practitioner for 25 years. I continue to work in direct clinical care with a background in primary care, in specialty care, including thoracic oncology, having launched a lung cancer screening program, tobacco cessation, and I continue to work in a primary care setting. But my day job is Chief Healthcare Delivery Officer at Go-To for Lung Cancer. So I'm a nurse practitioner, and always a patient advocate, and fulfill this role in this current setting. I interface with healthcare providers as one. So I'm in the field. I work in a community clinic that's a mobile unit that travels the city after hours. And I can say that workforce shortage is a huge problem. So from a healthcare delivery standpoint, we've got these problems, but that does translate to patients too. There is great fatigue for our patients to determine across the wild variation in our health systems and our care delivery models and our payment systems, particularly for people who are some of the most vulnerable and marginalized. Navigating the health systems can be nearly impossible, and that's not an exaggeration. And screening is a luxury for many people. So, primary care providers, the turnover, they just get secure, they develop trust, and then, oh, what do you know? It's time to transition. This equates to gaps in care. It equates to people experiencing hesitancy in reestablishing care, which is just one tiny but very large factor that goes into this equation of people getting screened.
Does anybody else want to comment on that from the panel?
David, this issue of insufficient actionable information rather than just loading people with information is what we're focusing on with our app development, is that in the app, there is a clear, specific action item, what to do, what it means, and then how to communicate this with your physician. If we just load patients, especially in the era of AI and abundance of information, chances are we are going to burn out patients or turn them off because you don't know what to do and you get so many things on one side. So actionable information, clear recommendation, what to do with it. Sometimes patients even provide that to physician. Physician is not up to speed with that particular things that they've read. So that's our focus, and we hope that we can actually demonstrate it once we start a pilot in Texas, where that this kind of app-based direct-to-consumer specifically define what to do and tie them. They have primary care physician, tie them to work. If not, provide them with one to get the next access. Unfortunately, for most part now, and I say unfortunately because I think we should have an AI system to prescribe a statin. It's just ridiculous that you have to get this to a doctor and lockbox it for that. We should be able to do that. But until we get there, we need to provide this actionable information that patients don't get burned out.
Well, and I think that we have to frame it in a way that respects the relationship with the primary care provider, or people start getting confused about who they should listen to, where they should go, and how to navigate that in very simple language, so that all can understand it, and maybe also translating those languages.
This is a big issue, this idea of the findings, and we're putting it in the reports, but are people listening? Do they follow up on it? It's a lot of uncertainty. I was just approached by a researcher in Mount Sinai from the family practice group who said, we report all this stuff. How many people are following up on this? What are they doing? We report emphysema, we report sometimes osteoporosis, coronary calcium. What's happening with all this information? Are people using it? I know you may have something to say about this, David.
I imagine that when a patient gets a report that they have something suspicious for lung cancer, they're pretty good at following up. Is that true? So what we're really talking about is the so-called incidental, forgive me for the terminology, finding in particularly coronary calcium. And I would say, especially with AI and the ability to deliver an image and a message, and then what Jamal was saying about referring or having a care pathway that includes a pharmacist, take the burden off the primary care physician. I mean, it's like Khurram was saying earlier today, it's a no-brainer. The patient's got coronary calcium, they should be on lipid-lowering therapy plus attention to other risk factors. Get them into the care pathway. And last reference to AI, there's this thing called chatbots. I don't know very much about, but chatbots should be able to answer questions that patients have directly, give them something to engage with reliable information that should, again, take the burden off the primary care provider.
Yeah, I think this whole area is going to open up how we transfer information to patients. We're already trying to design new reports. We have Rick Avila introduced us to a team that's working with us now about how to translate the reports and embed ways for patients to get information about the findings so they just don't see emphysema. They're going to know where to go to find out more information, things like that. I think this is a whole new generation of what's going to happen in terms of providing this kind of information to
Can I
people.
just add the chat bot, David, is effectively now more intelligent than a primary care physician. and they can effectively, there is data.
I wouldn't go there, Mort.
So.
You were,
we
you were
just
doing,
need
you
to
were
work
doing
it-
great up until
Maybe
this
a
point, Mort.
cardiothoracic surgeon, but not a primary. Oh.
This is happening, guys. We better go with it and not resist. This is happening. And we are trying to be at Harlan, to be on the front, to bring it to primary prevention. And we have a duty to do that.
There was a study done about a year ago when the chatbots answering patients were judged by the way on the empathy. And chatbots, maybe not smarter, but they are more empathetic, or they can be more empathetic.
More empathetic.
But there's also
share this.
information that the chatbot
I
doesn't
know, that must
have.
be compared to cardiologists.
I mean, we also need to be
I feel
thinking
like
about the value of a human ascertaining what intervention is the most appropriate and what other factors need to be considered when looking at risk. And that does take a human to take a look at that.
I just would like to respectfully take the opposite side, that we do not need a human to evaluate all aspects of risk. We literally have an AI that does the job better than I do. In terms of remembering all the things to ask you, in terms of remembering to connecting all that, I just can't compete with that AI. It just does a better job in evaluating. And again, as David said, there are things that we still have to work on, but to decide you should be on a statin or not, whether you should, we double check your blood pressure control level or not. We really have an AI that can do an effective job and make a massive impact at population level. We, as the policy developers or, leaders, we just need to move towards that direction.
As long as that AI has access to an accurate medical record
Absolutely.
to determine whether or not that statin is appropriate for that patient.
Yeah, so what I'm saying
And
is
what the
for-
risk would be to initiate a statin.
AI tends to be can be a great equalizer in
Yeah, I
terms
just
of
wanna
leveling
talk
the
about
playing
From
field.
the cardiology side, we really have that. We made it super simple as Quran presented, backed by data. You have calcium in your coronary arteries, you should be on a statin, unless there's an extreme rare case. So we want to make it simple, and AI can help to facilitate that and to get it to a large level. Of course, not knowing whether you have calcium or not is the biggest problem. And we don't have coverage for that.
Fred,
I would like to congratulate Dr. Rana on the results in cardiovascular disease. But I'd like to ask you about Southern California, where the research director is Michael Gould, who has had a very adverse effect on uptake of lung cancer screening. I would like to ask you, what is the uptake of Kaiser patients for lung cancer screening in the state of California? And anticipating that it's going to be very low, suggests that perhaps we should turn over uptake of screening to the cardiologists away from the pulmonologists.
Well, I'm sorry, I don't know the data because I'm not a pulmonologist and not an oncologist, but thank you for the comment, yes.
Training across the state like they did with colorectal cancer, so they know, but they're working on it.
Yeah, I'm gonna take that back and find that out. yeah.
Kaiser wasn't reporting its data either.
The NCI Cancer Centers, even the one who has a PI on the NLST trial, do a very, very poor job with lung cancer screening.
So,
Dr. Mulshine,
this is
are
excellent
you going to
stuff.
tell us about how good the session is? Yeah,
It was pretty good.
it's okay.
So, no, it's excellent. Okay. So, two quick points. There is a no-brainer equivalent to the no-brainer that Dr. Nasir suggested in the last session. And that is, despite the complexity, the message that could go back to virtually every screening participant that comes across this, because this is evaluation in asymptomatic populations, okay? If this is truly screening, we have a different time mandate than in the therapeutic realm, okay? And one of the things that, in addition to everything else that's going to be done that's important and good and evidence-driven, is that these people that are getting information back on their scan, if they haven't stopped smoking, they need to stop smoking. for lung cancer, for COPD, emphysema, for CAC, for osteoporosis. Okay, so that, you know, we do abysmal actually in smoking cessation across the board. And this is a chance where you're showing the picture, got people's attention, that coming back to them with a message and reinforcing them may allow for much greater success than cessation in the previous efforts, okay? Number one. Number two, exercise and weight homeostasis. We heard all this stuff about metabolic, inflammatory, whatever, yesterday. How much of that's driven by our epidemic of obesity that's colliding with tobacco in so many of these subjects participating? So exercise and weight loss, everybody across all these entities. So there's conserved messages of basic prevention that are relevant in kind of emphasizing in this context that are, many of them are very much evidence driven. And if we lose that, we're just missing such an important opportunity. No, so that's first. Second, real quick, the presentation from Kaiser was superb because it emphasized the importance of registries and creating a backstop of evidence so you can figure out what you're telling these subjects is good or bad through time. Because, you know, there's so many evolutions, so many things happening at once. If we don't capture this stuff in some ground truth, we're just going to be running around like, you know, drunken sailors. So
It's not too bad. You know,
Ella,
it's not the worst thing.
Ella will tell you all the information they got from the ACR registry, which was very valuable. However, they didn't capture images. And these images have so much information, as Dr. Maron and others have been talking about, that if we systematically capture some of these images and allow us to—
Jim, what are we, chopped liver here? What have we been doing? We've been capturing images
Oh, that's
in a pretty big
available as a-
registry.
That's available as open registry for national analysis on a regular basis for quality issues in these settings. It's got to evolve. It's got to evolve.
Steve has a comment.
I think we need to redirect the conversation here. What we really need to discuss is the failure to implementation in the US. And not the challenges to implementation. We have to acknowledge that at this point, less than 20% of eligible people, the Preventive Task Force lowered it, so it went down to less than 10%. And what we've heard are some successful examples here, which are based on special programs, a special mobile unit, a special program at the Phoenix VA, a special program for DOE workers. And that so far reliance on primary care hasn't been successful. So the question is, how do we go forward? Do we need to set up what they perhaps have done in Croatia, a national screening program implemented locally, but dedicated programs that are that pay attention to lung cancer screening and other things as well? And so let me ask Dr. Aguayo, because you've had that specific experience of trying the primary care route, it failed, you set up a special program and it succeeded. What do you think?
You're lifting a scab. It's so there is a national VA lung cancer screening program. It's funded part of the Cancer Moonshot, and it's the Lung Precision Oncology program. We argue with each other about who should lead how lung cancer screening is executed in the VA. And most people side with the oncologists who are really driving the Lung Precision Oncology program. And oncologists do not do lung cancer screening. They talk to patients after they're diagnosed with lung cancer. So they think they know what they're doing, but they really don't. And the primary care providers have been asked to join the conversation, but every other consequence that you see from all of this information that we gather is overwhelming. So primary care providers punt it. Then radiologists, it's great to participate in analyzing images and producing the information, but radiologists also don't talk to the patients. They need an intermediary. So by default, then pulmonologists have become the intermediary. So the middleman is who's driving the program. Everybody else is contributing information, execution, all of that, but it's really the middlemen are the pulmonologists. And they have aligned with oncologists, and they are doing the push system. So that's what's being tried right now. I'm not saying it's not successful. The VA right now has a registry of over 250,000 people enrolled in lung cancer screening accumulated over the past 4 years. And it's well on its way to have 1 million people participating in lung cancer screening in about 3 or 4 years from now. But there are missed opportunities because, again, the way that the program is being put together, all the information, for example, on the LDCTs that is being captured for administrative reporting purposes and quality assurance is the long RADS score. But the granularity of the CAC scores, the nodule consistency and size, rate of growth, all of that is not being captured systematically. So this is a long way of saying there is no consensus on how to execute it. I think publications are coming out comparing the push systems versus the pull systems driven by clinical informatics dashboards. And it will be a few more years before more facilities are using the pull system using clinical informatics.
Okay, we have about 8 minutes left. We have at least 4 questions, 2 there, Ella, and one of the Sebastians.
Hi, my name's Greg Mogul, 4D Medical. Might be the only person in the room who's a former Kaiser physician and a former military physician. So my question for you is about the VA. Deployment of lung cancer screening in the VA, as you said, is very variegated. The same thing happened when we deployed it at Kaiser, who should own it, et cetera. Except you treat a population that has a completely unique risk profile, different from everyone else in this room, given the percentage of people who've been exposed to toxic fumes, toxic dust from and burn pits, et cetera. Is there an idea or an approach within the VA to provide screening for individuals that were deployed and clearly have much higher risk for lung cancer and other lung disease?
1 minute for that answer.
So there is a collaborative MVP, Million Veterans Program, and Department of Energy project going on to scan 1.7 million records in the VA system, looking for factors other than tobacco exposure. That includes toxic exposures. You cross-compare with national databases about ozone, particulate materials, geographic areas of deployment and the time of deployment. So all of that is being fed into this model to try to improve the dashboards. And the challenge is going to be when we have those dashboards and you run it through the whole VA system, how to access those people and bring them to screening. We still have about 20% of our lung cancers are in veterans that have not smoked cigarettes, but the guidelines don't include them for screening. So we're playing outside the box and we're screening some of those. People have said that veterans have increased incidence of lung cancer compared to the general population. And so far, in the people we're screening, we are not finding that.
10 seconds. Okay, great. Bruce.
Hi, I'm going to be a little bit crude, but I'm an actuary. You know, in the handoff of information to primary care, and primary care wants to know what to do about it. There's something called value-based healthcare, and I'm going to be a little forthright in what it means. A new diagnosis of COPD, emphysema, whatever you want to call it, or osteoporosis, or a new diagnosis of coronary artery disease is worth $3,000, $4,000, $5,000 per year to a Medicare Advantage plan. And guess what? Most of Medicare is covered by Medicare Advantage plans. So getting that diagnosis into the electronic medical record and the The generation of the diagnosis is essentially free, and putting it into the EMR is essentially free, generates thousands of dollars per year to the Medicare Advantage plan. And by the way, that's what value-based healthcare means 95% of the time. If you want to know what value-based healthcare means when people talk about it, it's about generating revenue. And it's a bit distasteful, perhaps. But so I'm a little puzzled by the pushback. It kind of tells me, of course, what we want to happen is that primary care would do something about it. And that gets me to another question of why all the discussion is about primary care physicians when most primary care is delivered by NPs and PAs. And,
Yeah.
so we have a bunch of a bunch of doctors up there.
Well,
You're all
Yeah,
doctors.
let's have him wait.
Sorry.
We need
So-
really quick responses
David,
to his
so-
provocative question.
David, let's
So,
let him, right.
So if you look back at the history of other cancer screening, they can't all be the same because they're all different, right? See, that's deep. But breast took off because it's a woman's disease. Women felt very strong about breast cancer. Every woman's magazine had articles in it. Primary care didn't rush to recommend women for mammography. Women rushed to ask their doctors, should I get a mammogram? That started happening with colorectal cancer. It's not happening with lung right now. Primary care is acute care driven. If someone formerly smoked, they're invisible. We also have to keep in mind that this is a population that's low SES. They're hourly workers. A lot of them are in rural areas. And it's kind of out of sight, out of mind. And an emphasis on shared decision-making puts a huge amount of emphasis on, well, this is sort of your decision, not something that we're supposed to say, you should get this test. So the sooner we start measuring performance, which will be soon because we have a HEDIS measure coming out sometime in the next 12 months. If Medicare can start measuring screening, if we have a national campaign that says, if you are this person, if you smoked, talk to your doctor about lung cancer screening. We have research showing that we can successfully recruit women to lung cancer screening through mammography screening. And if we can roll that out, we can possibly influence their partners. But this is going to be a very hands-on effort because primary care is not going to wake up 10 years later and say, well, I guess we better start promoting this to individual patients, whether they bring it up or not.
And I
Let,
would say
let me
on-
add a little stick to that. For promoting implementation of lung cancer screening in the VA, the hardest thing that's happening now is the VA is handling lawsuits about inappropriate delay of care.
Yeah.
So there have been now several instances where a veteran who clearly was at high risk for lung cancer and should have been participating in a screening program for years was not enrolled and not offered the service, and the person unfortunately is suffering or dying from lung cancer. There are 3 such instances now. It's been kept pretty quiet, but it's already driving a renewed policy within the VA system to add performance measures related to implementation, execution, and clinical outcomes from lung cancer screening.
Okay, we have to go to the next question. Is that okay, Joelle?
Yeah, the last plug I would say is, if we're going to get all the people who need to get screened, we need to build smart, efficient, pragmatic health systems that call on every professional that is capable of supporting this effort end to end.
Good. Dr. Kazaruni, I think you.
David,
Sebastian?
I want to add the negative stigma of smoking going to get care. I remember the last meeting, one of the reasons we're promoting this heart lung screening is under the name of, calcium score or heart attack screening or prevention, there's no negative stigma of your smoker or you don't see any celebrity going out and proudly say, I was a smoker, I'm going to promote lung cancer screening, right? Whereas the Susan Komen Foundation proudly present breast cancer screening and raise awareness and build on it. So the approach towards a comprehensive heart lung can cover the stigma. This was brought up by, I think, the CEO of Prevent Cancer Foundation in our last meeting, brilliantly, like this would be a good cover to increase adoption of lung cancer screening because the negative stigma doesn't exist for coronary screening and cardiovascular.
Sebastian.
I have very short and quick, very practical comment on one of the few problems that AI cannot solve. It refers to Robert's presentation on the challenges of the mobile screening. UK operates a larger fleet of mobile systems, yeah, and what was a breakthrough there was that NHS made an agreement with Tesco, the supermarket chain, to use their parking lots and, more important, power lines of the supermarket. Yeah, this is a big benefit because it eliminates the need for the diesel generators, which, as you saw, are a big issue. Yeah, this is a very practical and probably very simple thing that may also work in the US, and you also have the advantage that if the truck is in front of the supermarket is normally a place where people go anyway, and supermarkets have high power requirements because of all the freezers and so on, so they have strong power lines, and this is basically a simple thing that worked extremely well in the UK to improve mobile screening and solve this issue. Yeah.
Many of us saw a presentation at World Lung in the last 10 days that introduced a mobile screening in England that is solar powered too.
That's in Australia.
Australia.
That's in
pardon me.
Australia,
It's
but it
done in
comes
Australia.
with a price
Same
tag.
thing.
Yeah.
So one of the things I want to add about primary care physicians, one of the intended goals when we started the mobile screening program was to create a centralized approach to it, not burden the primary care docs with going after their patients, but let them manage it as they wanted. But we established a program going for rural populations and those that weren't established with a primary care physician. Once we had that well established, our best referral into the mobile program is the primary care docs. They'll see the patient and then refer it into us to manage as a centralized approach.
Partnership.
Yes, a partnership.
Okay. Ella, you had the last question.
So many things, but I'm between you all and lunch, and I recognize that. So I just want to step back and say that in 2022 data, we're at about 18-ish% of people in the US have been screened. USPSTF approved it on December 30th of 2013, which means payers didn't have to start in 2015, and that's when Medicare started. To say that 18% is a failure, I am as passionate about getting implementation out there as much as possible. But if we look at the implementation rates of any other cancer screening, we're not doing that bad. And so I think we need to recognize successes so that we don't prevent people from wanting to continue to implement. So we need to recognize success to move forward. I think that's critically important. I have a couple other comments to make, but one question I have for the panel is we've seen in healthcare all sorts of consumer-centered online vehicles for getting their healthcare. And younger generations of people are shying away from having primary care physicians going online. Now that you can, in more and more facilities, download your CT scans from your electronic health record, not just your report, I'd really like to hear from you all. And what is your perspective on consumer-centered use of their own CT data? You know, AI tools, tools like this, online information, you know, get your CT scan, upload it to a site, get an information about your lung cancer risk, your coronary calcium score, and so on. So where do you see the consumer-centered components of healthcare with respect to the types of things we've been discussing?
I'll start right there. So
But I don't mean going to somebody for a CT. I mean, they own the CT. they've
yeah,
already
so
got.
if you open your open your X, Robert Lufkin, he actually just asked us, we basically announced patients go to our website, upload your CT scan, you get your bone density, he sells for $90. That's just exactly what you were saying, that patients now have access to their images, AI become available, FDA approved, you just need the website portal to go upload and get your results. Hopefully we will do the same thing for calcium scoring and for other things that like liver and fat and so on. So what you're saying about the new generation is what we need to look for. This is the new generation that we're going to try to eliminate coronary disease and lung cancer and so on. We should not look at the past and decide and plan for the new generation that's way ahead of us. They're using AI much faster than, the older generation. So I'm glad that you brought that up.
I think we have to wrap it up here. Thank everybody for a wonderful session.